Um, Good morning, I'm Jen Wells. I just want to make two admissions before we start. I know that's a bad omen, but I'm going to do it anyways. First, I like to keep my talks pretty entertaining. I like for you guys to stay interested for the hour, but let's face it, teen depression, suicide, and bullying is not that funny. There's not a whole lot of jokes for about teen suicide, so instead I've chosen to wear my sunshiny jacket to confer the happiness that my talk doesn't possess. And second, this is not a topic I talk about very often, so please excuse any blunders up front. It's my first time through, so we'll see how it goes. All right, with that, let's get started. Teens, trauma, and turmoil. We're gonna spend some time today talking about risk factors for teen depression, looking at bullying, types of bullying, how it impacts our teens in the long term, and then figuring out how do we change that? Where does resilience fit in, and how can you help your patients build resilience to be better, stronger people going forward dealing with adversity? So pre-test questions, these will all come forth in the span of the talk. What percentage of teens are depressed by age 18? Are teen suicide rates increasing or decreasing? It's really not a trick question. How many teens are on social media in the US? Sure seems like all of them. Child and adolescent trauma is something we're gonna focus on. I hope people are familiar with the ACE study, but we'll review a little bit about it just to give us an idea of how much trauma impacts teens, adolescents going forward, and then intergenerationally. And then can you recover and build resilience? So teens and suicide, woo, super exciting. Let's start by looking at the statistics. According to NIMH, about 11% of adolescents have a depressive disorder by age 18. That's a lot of people. And only about a third of those depressed teens are being treated for it, so are seeing proper mental health professionals, psychiatrists, counselors, LCSW, to get their needs met for dealing with it. And unfortunately, female teens are about twice as likely to develop depression as males. So about every 100 minutes, a teen completes suicide. If you think about that over the course of a day, it's pretty staggering. According to the CDC, suicide is the third leading cause of death among young people. It amounts to about 4,400 deaths a year. That's behind motor vehicle accidents and homicide. For every suicide that we see completed, there's about 100 suicide attempts. That's scary. About 14% of high school students have considered suicide, and I would bet it's much, much more than that. And almost 7% have attempted it. I'd like, as part of what your takeaway message today is that talking about suicide is really important and doesn't increase somebody's risk for committing suicide. We have to open up the discussion. It's the same across pretty much all psychiatric realms. Talking about the problem doesn't increase the risk of the problem occurring, it decreases it. Similarly in life, nothing gets better when it's shut in the dark, right? Everything needs exposure to light. We need to talk about what's going on. According to the National Bureau of Economic Research, teen suicide rates have tripled between 1950 and 1980. Suicide rates for white children ages 10 to 17 have increased 70% between 2006 and 2016. And they have increased by 77% in black children in that same time period. It's interesting that the African American rate has increased, though their total rates are lower. It is still white male teens who have complete suicide the most frequently. We also know that pediatric hospitalizations have more than doubled for suicidal thoughts and actions during this same time period, and about 157,000 teens receive medical care for self-inflicted injuries over the course of a year. So what do we look for? We're going to talk a little bit about warning signs and risk factors. And they're a little bit different. Warning signs indicate an immediate risk of suicide. So not like you got to call 911 and they have to be admitted to a psych unit, but they're sort of on the trajectory towards depression, towards increasingly impulsive behavior, towards suicidal ideation, and then perhaps a suicide attempt. The suicidal crisis has already begun. A risk factor is more static. It increases the probability that a suicidal crisis will occur, but not necessarily that you're in the midst of one. So warning signs for teen depression include, not surprisingly, feelings of sadness, hopelessness, isolation, declining school performance, loss of pleasure or interest in social and sports activities, sleeping too much or too little, changes in weight or appetite, nervousness, agitation, irritability, and that becomes a pretty prominent factor. Anxiety is a particular risk factor because it pre-predicts impulsive behavior, which then predicts suicidal behavior. And then we know and have known for a long time substance abuse is a big warning sign for teen depression, for teen suicide, and completed suicide attempts, the whole myriad of them. And that includes THC. If any teen is telling you, it's fine, my doctor said it was fine, I can't make this up, I hear it too. Oh no, it's fine, like my family practice doctor said it was fine. It's ridiculous what they tend to believe, and I say, have you been on Google MD? Are you doing your own medicine now? Like, let's hold on, let's back it up. And it doesn't work so much to give them research. You have to give them either practical knowledge or just your best data to say, hey, listen, it's not safe. You're changing your brain in ways that can be unalterable for the future and change the way your life trajectory goes. So I'd sort of think about what you're doing and what your friends are doing, and if it's something you want to participate in. Like heavy-handedness doesn't work, and then ignoring it doesn't work. It's tough. Teens they're a rough crowd. So let's look at some warning signs for suicide. They generally fall under 3 categories: health, environment, history. So when we talk about warning signs in health, we're talking about depression, substance use disorders, chronic health issues and chronic pain, because those can occur in kids. Any children that have a history of cancer can be at increased risk. Anybody who has chronic sleep issues is at risk, especially in children that are highly motivated to do well in school and they decide 4 and 5 hours of sleep is enough so they can complete all their homework for their AP courses. They can be particularly at risk. When we talk about environment, we're talking about stressful life events, things happening in their families, in school, access to guns, financial issues. And history, so previous history in the family or in the patient, and any history of self-harm. So this one up here, not surprisingly, warning signs for suicide include sadness, withdrawal, losing interest, that sleep that I talked about, and an interest in death or dying. That's a common one that comes up, and it's hard to delineate, right? Because now we have things on TV like 13 Reasons Why. And it's the big hit, and everybody wants to talk about suicide, and a part of it is really positive. Like I said before, it's opening the door, it's creating discussion, but when you take a bunch of teens who might be alienated at school, don't feel good about their progress, feeling awkward, as pretty much every 7th, 8th, 9th grader does in life, and you put them together, their ability to rationalize and see the difference between a discussion and the reality, it becomes marred. And they might progress to increasingly erratic behavior just because they build on one another. So more signs, engaging in dangerous or harmful activities. So more and more reckless behavior, staying out, doing more drugs. Self-injurious behavior is a big one that comes up. It is sort of de rigueur now for teen girls to cut themselves. They share it on Facebook and on Snapchat and on Twitter, and it's hard to understand how these mechanisms occur, but they do. And the way, again, is we have to talk about it, we have to open up the discussion and suggest other means for coping, which we're going to get to later on. It's also common for adolescents to give away favorite possessions, to start saying goodbye to people. So sometimes it's hard, like romanticizing death as stuff before, writing stories, poems about death, dying, suicide, saying or expressing they can't handle things anymore. It won't matter when I'm gone. I don't know how many of you are parents to teens or are seeing teens regularly in your office. These are sort of common sentences out of their mouths, right? They tend to black or white think, they tend to catastrophize, and so it's hard to read whether it's typical teen being aloof or it's a true sign of suicide. So the answer has to be, you just have to inquire. You can't let those statements rest. You have to say, like, hey, what was that about? And if they're like, oh yeah, it's nothing, don't even worry about it, you have to press it. Well, no, it could be important. I get it. Sometimes it just feels like everything's too much. Or is it really, are you really thinking about suicide? Have you had thoughts of wanting to hurt yourself, kill yourself? What's going on? And a lot of times that's all it takes. One or two, and they'll break, and the tears come, or they admit what's going on at home, and it just takes someone who has a moment, one or two sentences, to question the response and say, hey, how can I help? So risk factors for suicide. These are the more static things: one or more diagnosable mental or substance abuse disorders, impulsive behaviors like self-injurious behaviors. Drug use ranks up there with impulsive behaviors, undesirable life events or adverse childhood experiences. We're going to talk about that in a little bit. Family history of mental or substance abuse disorder, or a family history of suicide. Some people say, that it's completed suicide, and other people will say it's a risk factor just if there's an attempted suicide in the family, because it increases sort of the idea around suicide. There's a talk in the literature about the contagion of suicide, that in a family system, if there's one person who commits suicide, in the immediate months following the trauma, there's an increased risk for all family members surrounding that one person. We know that family violence, physical, sexual, verbal, emotional abuse increases your risk. Prior suicide attempt, a firearm in the home. I can't tell you how many times, you have to, especially in my state, I'm from Virginia, but it's probably true in South Carolina too, like everybody's a card-carrying member of the NRA, and so I try to, it's important, I think, to instill good gun safety at home. Do you have a lockbox? Is it kept separate? Are the bullets unloaded from the gun and put in a separate place? To have a loaded gun in a home with a child doesn't make a lot of sense from a psychiatric perspective. Incarceration in families, and exposure to the suicidal behaviors of others, family, peers, in the news or fiction stories. So the same thing I talked about, like 13 Reasons Why. There's been a lot of media coverage about what do you do about it? Should it have been banned? Should it show it? Can they say whatever they want? And I think at the heart of the discussion is just that you need to talk with your patients and your children about what it means to feel suicidal, what that behavior looks like, where you go for help. How do we open these discussions? So this is just an interesting slide. There's a tendency in adolescence for suicide rates to increase just at the start of the school year. So just for you guys that do well child checks or have adolescents coming in for their school physicals, you might want to be mindful of the fact that, in fact, rates increase. And you can see in the purple just that rise, July, August, September, October, November, right? There's just a slight increase. So it's important that we're aware and we're asking our teens whenever they're on their way back to school. I mean, it's sort of important all the time, but you guys don't have all the time in the world. So at least when you're doing your major yearly checkups, that you're asking the right questions. So what's your role? You want to know your at-risk patients. So just like we discussed, 90% of suicides involve someone with a psychiatric disorder. So your teens and adolescents who have a known history of depression, anxiety, substance use disorders. Bipolar disease can't technically be made in an adolescent, but the signs can be there. So if that's someone who's emotionally labile, they're thinking they're bipolar, has had a psychiatric hospitalization, those are people you maybe want to have on your radar. When they come, you might need to take a couple extra minutes to do a quick psychiatric review of systems to make sure they're not suicidal. Severe anxiety or agitation, as I said, can predispose you to parasuicidal behavior, so self-injury. It's like poor impulse control. You act out, you externalize your behavior, and so those are people you want to keep on your radar. And knowing that if you have multiple risk factors, you have increasing risk. So if you're doing poorly in school and you were hospitalized for depression a year ago, and your dad goes off to jail, and you failed school, and you've started smoking pot, right? That is a person who's at tremendous risk that you need to ask about. So if we don't ask, then teens don't tell, right? They just tuck it away. They won't talk. You have to dig in. And you don't have to be entirely grossly intrusive into their lives, but you have to push them a little bit because they tend to be kind of aloof. And sometimes if they don't trust you, they won't open up. So you have to give it a little nudge. And the yield is low. A lot of teens are just aloof and angry and trying to figure out how to make it in this world. And it's a hard, society we live in right now. Social media, intense political divisiveness. It's a rough road. So you got to ask everyone. Your yield's going to be low, but the stakes are pretty high. Okay, so let's look at bullying. Some statistics. According to a 2008 study, bullied children are 2 to 9, 10 times more likely to report suicidal thoughts than other children were. That's not surprising. So then you say, well, where does bullying come from? And we know a lot of it now is coming from social media outlets. And so how many of our teens are on social media? And it's sort of all of them. 95% 12 to 17-year-olds use the internet. About 80% use social media sites. So that's a lot of people. And there's a lot of ways to confer damage across these mediums. 9% of these 12 to 17-year-olds have been bullied via text message. 8% experience electronic bullying through email, social network site, instant messaging in the last 12 months. So when the CDC looked at this, they found about a quarter, almost 25%, 23.7% of girls have been bullied on school property one or more times in the 12 months prior to the study. That's a lot of girls. 21% said they'd been bullied across electronic means, so email, text, websites, and about 9% of those high school girls did not attend school. So now people are staying home. They're not getting their education in the previous 30 days because they didn't feel safe in their school environment. So what is bullying? It's unwanted, aggressive behavior among school-age children that involves a real or perceived power imbalance, and the behavior has to be repeated or have the potential to be repeated over time. In order to be considered bullying, the behavior must be aggressive. It includes an imbalance of power. Kids who bully use their power, such as their physical strength or their access to embarrassing information or perceived embarrassing information, or use their popularity to control or harm others. And the behavior has to be repetitive or has to have the possibility of being repetitive. The bullied has to feel the threat that it could occur over and over. Now, when it comes to treating patients who have been bullied or are bulliers, I think both populations need attention. So we're not going to solve the problem from going from one side of the equation. It is both who need help, and largely counseling, sometimes psychiatric intervention, sometimes medication management, but not often. So bullying includes making threats, spreading rumors, attacking someone physically or verbally, or excluding someone from a group on purpose. It can be in person, through technology, electronic aggression, or cyberbullying, as they now call it, if email, text, social media, websites, or other digital applications. I was reading about this like 2 nights ago, and there's like so many applications that I've never even heard of that I think are like day-to-day use for teens, that are ways you could manipulate data and bully someone. So types of bullying, there's verbal, saying or writing down mean things, teasing, name-calling, inappropriate sexual comments, taunting, threatening, or physical bullying, threats of a person's body or possession, so hitting, kicking, spitting at someone, also taking or damaging their things, or using rude or demoralizing hand gestures. And then there's the social bullying or relational bullying that's becoming all too common. Involves hurting someone's reputation or relationships. So leaving someone out of an activity on purpose, telling other kids in a group, let's not invite them because we don't want them to be part of our stuff. Spreading rumors that aren't true. Embarrassing someone in public. And is any of this new? No. But the means by which a rumor can spread is tremendously faster now. Before, you had to tell ear to ear in school or pick up your phone and dial the number. So that's how long ago it was. Right? And who wants to dial 8 numbers, 7 numbers? I don't even know the amount of numbers in a phone anymore. To call your friend Betty and be like, oh my God, did you hear that Susie did this? Right? But now it's a quick text, boom, done. And that can be spread. And things even go viral, right? They go to millions of people. We've seen it. That's a lot on a teen. To think that thousands, hundreds, thousands, millions of people might be exposed to your blunder at school. That can be a lot to put on someone. So there's just the graphic of the girls in high school. Almost a quarter experience bullying on school property. 21% experience electronic bullying, and almost 9% didn't go to school in the last 30 days because they were worried about their safety at school. Those are impressive numbers. Okay, so what are we going to do about it? First, we got to make a stop at the trauma bus. So, are you guys familiar with the adverse childhood experience study? No, we're not. Okay, big public health study came out over a decade ago, examined the health and social effects of adverse childhood experiences throughout the lifespan. They looked at about 17,000 health records from Kaiser Health Plan in San Diego, California. And what they were trying to figure out is that if you were subjected to trauma as a child, did it have any impact in the adult you would become? And the results were astonishing. So first what they looked at is what do we mean by adverse childhood experiences? They called it child abuse, neglect, growing up with domestic violence, substance use disorders, mental illness in the home, parental discord, crime, even death. So anything that might change the dynamic of relationships within a family was included. And what they did, this triangle is pretty common, but they looked at the mechanisms by which these childhood experiences might impact health and well-being throughout the lifespan. And what they noticed was if you have adverse childhood experiences, you are more likely to have social, behavior, emotional problems, cognitive impairment, early death, and health problems, like physical health problems as a result of experiencing trauma. And two, and I'll talk about this more tomorrow, there's some epigenetic transmission. The actual experience of trauma, particularly in a mother who's pregnant, can change the genomic structure in the fetus such that there's transmission of cognitive and physical health changes through the lifespan of the fetus. Like that to me, mind blown. You guys don't seem as impressed. Okay, so ACEs are common. Across The U.S. Substance abuse, or across this study, substance abuse was the physical abuse was the most common, 28%, and substance abuse was second most common at 27%. But you can see the experience of childhood trauma is not limited to the very few. Now, when we take that and look at adolescent girls, what happens? Well, when they looked at their 17,000 17,000 patients of Kaiser, they found that almost all aspects of adolescent health were impacted by childhood trauma. So reproductive health worsens, increased smoking, increased drug and alcohol abuse, increased sexual promiscuity, increased mental health problems, increased chance of re-victimization, increased instability of relationships, increased risk of homelessness, decreased performance in the workforce. I mean, could you pick a worse thing to have? I mean, it pretty much hits every major value center in a teen's life. And if you needed some graphics, these are just a few I pulled from the study. So increased teen sexual behaviors by increasing ACE numbers. So the more ACEs you fall into, you've been a victim of abuse, you have a parent in the home who's gone to jail, someone is suffering from depression, someone had a suicide attempt, you're at 4 right there, you're in the yellow. You have increased chance of having early intercourse, increased chance of pregnancy as a woman, increased chance of teen paternity as a boy. You have an increased chance of having a mental health disorder. You have an increased chance of being put on an antidepressant medication. You have an increased chance of trying to commit suicide, and you do have an increased chance that you will complete suicide. So it's striking and it's sad, and there aren't a lot of mechanisms we have right now to prevent this, because that is what has to happen. If we're going to change the picture from adverse childhood experiences, we have to work in a model of prevention. And it means from the earliest stages that we're talking to parents about what trauma looks like in the home, how unsettling it is for their children, and we're talking to kids, toddlers even, toddlers, children, adolescents, young adults, and adults going forward about what it means to handle trauma. How do we become resilient? So this slide just encapsulates a lot of what the Adverse Childhood Experience Study brought us. And I just think it's really profound that 4 or more ACEs has 14 times the number of suicide attempts, 11 times the number of IV drug use, and 4.5 times more likely to develop depression, right? It's pretty clear that it's a pervasive problem that needs some public health attention. But thankfully, it's coming. Okay, so just as a recap, ACEs are cumulative and synergistic. We know that child maltreatment victims have about 2 to 7 times higher risk of being re-victimized in the future. ACEs increase risk for major public health concerns outside of mental health, also for liver disease, heart attack, cholesterol, diabetes, far in excess of usual thresholds. ACEs are often transmitted from one generation to the next. That's what I was talking about, that epigenetic transmission. So education and prevention is fairly critical. So what are we going to do? So what's this resiliency crap that everybody's now talking about? There's this great book out. It's called Resilient by Rick Hansen. He's a neurophysiologist. I love him. I go to lots of talks by him. If you have time, he also wrote Buddha's Brain. If you have time to check it out, it's a pretty interesting read, and it has really helpful advice for just a person personally, as well as far-reaching implications for our practices, our patients, anyone we come in contact with, including our family systems. So how do we build resilience? Science tells us that some children develop it, some don't. Are you just born with it, or do you got to work at it? Well, like most things, you got to work at it. According to the State Department, resilience refers to the ability to successfully adapt to adverse situations, to manage stressors while maintaining psychological well-being in the face of adversity. It's your ability to bounce back. That's like the quick and easy term for it. It's important to know that it's a process. You aren't born, I bet it is true to some extent, you're born probably with a little more either protective or risk factors for being resilient. You know, there's the idea of the orchid or the daisy child, and I'm sure the daisy have a little easier time building resilience than perhaps an orchid child, but it is something that you build. There are strategies, exercises, things you can do to build it. It's dynamic, it's changing, and it starts from infancy onward. Breastfeeding moms are building resilience one breastfeeding meal at a time. Bottle feeding moms, holding their babies close, building resilience one bottle at a time, right? Attentiveness with a structured caregiver is the single most important factor for building resilience in anyone. So when they look at kids, what factors predispose children and adolescents to more positive outcomes in the face of adversity? Supportive adult-child relationships, building a sense of self-efficacy and perceived control, providing opportunities to strengthen adaptive skills. They need practice. You've got to work at it, and self-regulatory capacity. So making it easier on a child doesn't help build any resilience, right? They have to go through some things to learn how to self-regulate and cope. And you can mobilize faith, hope, and cultural traditions in order to help do that. So the single most, as I said, single most common factor for children and teens to develop resilience is having just one stable, committed relationship with a supportive parent or anyone else. So it could be us in our practice, in our treating rooms. I think I'm that for several of my patients, but that's some of how a psychiatrist functions, and maybe less so for you guys. But we all know doctors are respected, even revered in a lot of communities, and so you have the opportunity to be that one stable, caring, present individual for a struggling teen, adolescent child. Having a parent or a caregiver provides personal responsiveness, right? You're right there. You give scaffolding. You teach them how to be people in the world, and you offer protection just by your stability, just by being there. I say a lot to my patients that they borrow on my ego strength. I show up every day, I'm competent and happy, and have made my way through the world after significant adversity, and that confers in me a sense that I can do it again. And my patients borrow that from me when they don't feel like they can do it. If I say, listen, I've been through some stuff and I think you can do it, that emboldens them to go forward and manage their own crises. So this combination of supportive relationships, adaptive skill building, and positive experiences is the foundation of resilience. So here's 10 tips. Got bounce? This comes from the American Psychological Association, and they're things you could easily share with your adolescent patients. Advise them, get together. Like, teens need to talk. They need to socialize, but it also extends to talk to your parents, include them in some of your issues and problems. They might not believe it at the time, but generally their parents have been through some things as well and might provide some valuable feedback. So you want to encourage teens to look into that. You want to tell them they need to cut themselves some slack. They often hold themselves to very high standards, are incredibly self-critical just by nature of being a teen and managing the transitions of being an adolescent, and they have to learn to be able to ease up, to recognize what's important and what isn't. Oftentimes I say, do you have a place in your home you can go that's private? Is your room private, or do you have a room where you and your friends can gather? It can even be a park. I do some group therapy, and my group therapy room, I think, is our hassle-free zone for a lot of my girls. You advise them, when stressed, to stick to a program. Habits and routines, when healthy, are really important, like eating 3 square meals, making sure you're sleeping 8 hours. Sometimes in the midst of a loss or a great trauma, the simplest routines can confer a sense of control that helps somebody cope and be more resilient. You have to teach them to take care of themselves emotionally, physically, sleeping, eating, making sure they're going to school if that's the age group they're in, so that their physical health doesn't decline, because that's going to exacerbate any mental health issues. I advise them to take control. Make one small decision a day. When everything feels like you can't do anything, make one small decision. Something that's good for you that you could do. And it can really help them to feel like they're making steps in the right direction. You have to express yourself. You have to get it out. Not talking about it, shutting it down isn't going to help. And it doesn't have to necessarily be to someone, although I think in the long term that probably does facilitate faster healing. But you can do artwork. You can start a journal. You can get a tattoo if you're old enough. But there are things that help you get some recognition, put it out there so it's not eating you up inside. And of course, we're probably all familiar with this, help somebody else. Generally speaking, when you're in misery, if you turn around and help somebody else, it helps you to feel better. And a lot of the people that I treat will say to me, like, Dr. Wells, nobody wants to hear all the crap I have to say. And I say, when someone comes to you with their problem and unloads on you and you make a suggestion, they're like, oh, hey, that's a great suggestion. I say, do you feel better? And they're like, oh my God, yeah, I feel so much better. I say, does the other person feel better? Oh yeah, I think I really helped out. And I was like, well, how about you try that? And I think it really does work. And then putting things in perspective, right? Teens have a tendency to catastrophize, to make everything the biggest problem that ever happened anywhere to anyone, always. And they don't have a lot of the, today's newspaper is lined tomorrow's trash cans scope. And so you can provide that. And even as physicians, you can reflect that back. And then turn it off. Sometimes, even if you're not concussed, you have to put the phone down. Creating family time in your house is a great idea. Saying, like the news maybe isn't a good thing for you to watch tonight. There is a lot on our TV screens now that is inappropriate for child and teen ears and eyes. The content is too dramatic and isn't well weighted towards helping people cope with mental health problems. So turn it off, get them away, choose other activities, go for a hike, get outside, walk the dog, read a book, do a puzzle. There's a lot of other healthier media out there to help you cope with adversity. Okay, so what can you guys do day to day in your practices? So include your younger patients in discussions about their care. I know sometimes it's hard when I have a kid under 18 and I have to have a parent consent to everything that goes on in terms of medication. It feels like sometimes the kids lose their way or don't have a role. And so I see them separately and bring the parents in at the end for a recap. And that helps foster a sense of trust between the two of us. But it might also help you when you're making birth control decisions or anything else about their health. Keep an open dialogue with them, not the parent. Enlist support as you need it. Of course, refer to a psychiatrist. So if you're seeing mood fluctuation, if you're seeing warning signs of depression and suicide in one of your patients, it's an easy call. I hope there are psychiatrists in your community, but that's where the call needs to go. It has to go to a mental health professional soon, if not emergently. And you want to customize your advice just day to day. It's building on that thing I was talking about before about your patients can use your ego strength. I am a mirror for my patients. I will tell you I wasn't here last year because I went through a very exhaustive battle with cancer, but I won. Well, for now. Let's not count our chickens before they're hatched. Thank you. But I think it was a super valuable thing for my patients to see me go through 22 rounds of chemotherapy, 3 surgeries, losing my hair, gaining 25 pounds, that I still came back, right? My practice, and not that I want everybody to have cancer to show they're resilient to their patients, but it provided a really good opportunity for me to show them, to mirror optimism, resilience, coping strategies. And that's what you can do just day to day. Like, it depends on how comfortable you are with personal disclosure with your patients, but you can often say, like, hey, sometimes when that happens to me, or I went through this, this is what I did, that does help them. So you encourage their inner Tigger. Optimism breeds optimism, not negativism, right? Being self-critical, being self-denigrating, that only brings you further down. We have to learn strategies for building optimism and strength, resilience, powerful feelings of hope and goodness about ourselves, and that's what the book Resilient is about. So you can do that for your patients. You can help them. If they're telling you all the things that are wrong in their lives, you can be the reframer. Hey, did you ever think about it like this? I'm sure all of us have a familiar experience from our own lives where something seemed super bad, or it really took us down a rabbit hole for a little while. But over time, we worked our way back out, came back up to the surface, and have something positive to report back on what was once a very adverse experience. Your patients can benefit from knowing that you've been through that too. Because again, you're really respected in your profession. A lot of my patients don't think anything bad happens to me ever. It's sort of crazy, but it's true. And so I tell them about some of the things I've been through. Cancer was certainly the most visible thing that I've been through, but I tell them about other struggles that I've been through, and I think it helps them know that if I could do it, they might be able to do it. So we know that gratitude, altruism, and a sense of purpose also predict resiliency. So thanks. There are some resources. Let me just tell you, in case you need ideas for talking, mental health discussion, resources including crisis lines, those are all right here. There's a national clearinghouse list of 1-800 numbers for mental health disorders, abuse, suicide prevention, depression, domestic violence, etc. So thank you.